So two things I want to focus on. Microdomains. And there's a lot of question on explainability. Where is that coming from? And as Dusty pointed out, we have a booth. We have a deep dive that we can take if you stop by. So just a few, big picture items is all I'm going to cover. And when we designed this platform, the SpaceIQ, there were a couple of things that were very much in our mind, which is that the platform should be able to help you verify the hypothesis that you have, and also be able to generate new hypotheses, because there's a lot of emergent biology that you care for. And then we wanted the software to have a broad platform coverage. And that was actually a very useful exercise. So we think that we know a lot more about every platform out there than when we started. And then you want to be very good with how you think about these signals. You have to build trust in this data set, and you want this to be reproducible. So you think a lot about that. And then there is going to be uncertainty. So you have to find a way to handle that uncertainty from the time you pick up those photons and then take them all the way to the pathways, right? So, and we're all been in this space wherein you spend a lot of time trying to collect good data, and in the end, if you're, for whatever the constraint, you're not spending as much time in actually interpreting it. So there's a huge imbalance that we want to correct with the SpaceIQ platform. So you spend actually more time interpreting the data, and then we have the tools to enable how you can reduce all the effort that goes in to clean up your data sets, right? So two pieces, hypothesis generation piece and the hypothesis verification piece. Lots of tools, modular, scalable, lots of APIs. Again, come to the booth. I'll take you through a whole lot of them. Just to highlight things like how you clean up the QC, QA, SpaceIQ platform as a way to mitigate all that. So here's some of the processing that gets done with these images in an unsupervised manner. And then off-the-shelf cell segmentation, I can't find one person who is happy with the segmentation that they work with. So here's a case wherein if the tissue is dense, clearly you lose out on a lot. So you have to bring in the biology. You have to be aware. The algorithms have to be aware, in other words, of the fact that this tissue is in 3D, but the image is in 2D. So how does that really affect and impose constraints in how you do the segmentation? So SpaceIQ thinks a lot about the platform, lots of modules to think about this, and do a damn good job with the segmentation. Come to the booth. Let us take you through some deep dive. And I want to now focus just on two things. How do these microdomains come about, and what can you do with them? So this is the case that Dusty already mentioned. And the idea with the cell typing, and again, there are dozens of algorithms out there, but what we guarantee with this platform is that the decomposition is numerically stable. And just a very quick way of seeing that is every node has a color. If it is a green color, that actually I can point out that that's a very stable cluster, and there's no need to rethink about what's going on there. And the second thing is that it comes out, the biology speaks for itself. So this is a case wherein we know what biomarkers are being utilized to make what segmentation and what phenotyping possible. In this case, the metabolic markers, the SDHA and the ASCT2, make a difference in highlighting the cells on the right side. This is just a painting of how much heterogeneity is there. And then the first tempting thing to do is just to count the number of them and see whether that's good enough to be able to tell the responders versus non-responders. Very often, that's never good enough. And then you're really asking, you have to go back and think about what the platform can offer you in terms of communication and quantifying cell-to-cell communication. Here, we have a very unique perspective. We go back to the very basics. Regardless of the machine learning algorithm in place, the question that you're asking is that if there is a tumor cell, can this tumor cell anticipate the presence of a macrophage? So this is about predicting the identity of the nearby cells. It's just not co-occurrence, it's really about prediction. Huge difference, huge nuance. Come talk to us as to what that means, because then you have this way of thinking about what interactions really show up as being differential between the two cohorts. So the red lines and the blue lines are a way of communicating what is different between the patients that recur and for the patients that do not recur. And what happens is that you can take any one of those. Every one of those line is a prognostic model. So here's a case where we connected, there's a microdomain with 3 of these cell types, and you can actually sit down, interpret it, because that explanation is coming through as to how these cell types have been defined. So here's a case wherein the tumor cells, which are the very dark, bright green, they're surrounded by this fibrotic wall and also the macrophages. And you'd like to think that that's effectively creating an immunosuppressive environment to do so, right? And then there's a huge difference. One is about finding which cell is next to to the other cell. But the picture on the right says, what is the reason? What is the mechanistic reason why these cells, and what exactly is the communication? So some very interesting ways to think about novel drug targets and such. And then what happens with every one of those lines, as I said, is a prognostic model. So you can build a family of prognostic models from which you can pick and choose the sort of performance that you think is important for your data set. You can map it to the pathways, as I said, for novel targets and repurposing. And then finally, the same idea of microdomains also helps you put together or integrate this multi-scale data sets. In this case, there's a single cell and spot level transcriptomics data, and there's a spatial proteomics data and the bright field pathology data, and they're not necessarily consecutive sections. So how do you make the HND speak to all these data sets and relate those properties in HND and identify some new biology? We can do all of that. Again, come talk to us. We have 2 deep dive dates, 28th and 29th. Thanks, Dusty.
Thank you, Chakra. So we are delighted to have Dr. Arutha Kulasinghe from the University of Queensland, our key collaborator for the last few years. And Dr. Kulasinghe is probably the #1 KOL today in spatial biology, at least that's what I think, and many others think. So welcome, Arutha. Delighted to have you, please.
Thank you, Dusty, for the invitation. I live in Brisbane, Australia, and so making it to AACR every year is quite a challenge. And so we'll talk to you about some of the really exciting work we've done working with Chakra and the team over the last couple of years. So I'm based at the Fraser Institute, University of Queensland, really exciting sort of lab, leaning on the clinical end and translational end, where we're trying to understand predictive biomarkers for checkpoint inhibitor therapies in lung, head and neck, and a number of other tumor types. So Eric Topol, I wish we coined this earlier, and he coined this spatial medicine term late last year, and I think this is where the field's really heading. This beautiful shoreline where he explained the skin cancer story really well, and so nature took this and then they leaned on it and they're calling it tumor geography. And so spatial is nothing new to us, but spatial medicine is potentially where this will hopefully go in the near future. This audience doesn't need to be told why checkpoint inhibitor therapy is important, but it works in a number of tumor types where a subset of patients respond to checkpoint inhibitor therapy, and really defining these is really important. An article a couple years ago showed that I did my PhD in the liquid biopsy space, but realized really early on, understanding the tumor and the tissue, and then that's fundamentally where immune cells act, is really important. So getting that visual data simultaneously with your molecular information is really, really important. There are a number of predictive biomarkers in this space, PD-L1, TMB. They're limited in their dynamic range and how predictive they are. And what we try to do in the lab is to mine every cell within a patient's biopsy, surgical resection, and so on. And so why this is important is if we looked at it using a bulk expression analysis, we'd get very similar scores, but you could see on the right the tumor is highly infiltrated compared to the one on the left. So getting the visual information simultaneously with your molecular information is important in predicting these clinical endpoints. These are some of the studies that are ongoing in the lab in lung cancer, head and neck, both retrospective and prospective studies, in breast cancer, colorectal cancer, and we're looking at multi-site, multi-institutional studies where we're trying to develop robust signatures. It's not about N of 1 studies, N of 2 studies, which you'll hear a lot about. It's really about how does this scale across institutions and so on, and we do a lot of work in infectious disease as well, looking at the impact of viruses across multiple organs. And so working with Chakra and the team, one of the challenges we found was in scaling spatial biology. The informatics companies out there are they are very black boxy, and so how do we sort of get a lens a bit deeper and try to understand it? And one of the delightful things about working with PredxBio was we were really able to get a feel for how this is done, and it was an ongoing discussion across multiple data sets. So this is in a lung cancer second line IO versus standard of care cohort where Dusty spoke about the recursive cell typing. So we had responders, non-responders to second line IO therapy, and we could start to contrast. I love the visual data, right? So I love numbers too, but actually seeing it on tissue is fundamentally where we can start to interact with pathologists and really understand what we're looking at. And so this is in resistance. This is just two examples. In resistance and response to therapy, you can clearly see the microdomains that are identified in these tissues are completely different. And we can see this across the entire cohort. So these are tissue arrays where we're doing about 45 patients per slide, single biopsy cores. And these patients, so these are pre-IO specimens where we have the PFS data and OS data for all patients. And so we can start to contrast the microdomains between the responders and the non-responders. And the panel that we used was not just based on immune cell function, it wasn't just immune cell status, it was looking at both tumor markers, immune markers, functional status, metabolic activity. And so we tried to use this sort of multiomic level of information to be able to subtype, because we think at a phenotype level alone, nothing's going to pop up. You really need to dig into the subsets of the cells, and the only way you can do that is by functionally annotating those cell types. And so we can start to see that there are these clear distinctions between your responder and your non-responder microdomains in these tissues. And for example, we're looking at here in the tumor, ECAD positive, pancytokeratin positive in the tumor, but also the HLA status, proliferation, and SMA. And what we find is that in the patients that are resistant to checkpoint inhibitor therapy in the second line setting, we find that these tumor cells have these fibrotic walls on the periphery that are preventing your immune cells from infiltrating. And so you would have heard from Joanna Joyce's talk this morning, beautifully showing that, scarring and, this fibrotic activity. And it's not just cancer. We see this in the lungs of COVID patients, right? There is this fibrosis at play that's defining resistance to therapy, but we're also seeing it in multiple other conditions. There's actually an association of having fibrosis and your long-term sort of outcomes to therapy, irrespective of disease. And so we see these fibrosis like signatures that are defining resistance to checkpoint, and then we can contrast it to patients that are actually responsive. And so the microdomains that pop up here that are in this responsive phenotype is a citrate synthase positivity in your immune cell subsets. And so it's actually showing that in patients that are responsive to therapy, we're seeing higher metabolic activity, specifically in the immune cells. And so when we contrast this across the two, you see on the left there, those are patients that are responsive to therapy versus those are patients that are resistant to therapy. But if you think about this, the markers that we're using to define both response and resistance are not 40, 50, 60 colors. They're probably 3 or 4, right? So how do we define a minimal signature for response and resistance? And I think there's some lessons in here, and we're demonstrating proof of concept, but obviously we need to scale some of that information. And so we can start to look at this at the cohort level in responders and non-responders. TMAs are great where you can get a lot of tissue on a slide, and so we can identify the microdomains here between the groups. And then these were patients that were given Nivo, and so we can start to look at the mechanistic properties of them, and on these circus plots, how they associate with both response and resistance to therapy. And so Chakra spoke about this earlier, and Dusty. So we find in this cohort of patients that there's this response feature that we're identifying in this metabolically active subgroup, which are present in an immune cell type, but then also this resistant population which is associated with this fibrosis, and we think it's linked to an EMT-like transition. I'll quickly go into the head and neck just to end. And so head and neck's on the rise. It's sort of opposite to cervical cancer. where we're seeing a lot of sort of early stage patients with oral lesions, 20, 30-year-olds with oral lesions, and we're really trying to understand what's going on in these tumors. This is in a cohort of patients that have received immune checkpoint inhibitor therapy, and these patients had recurrence or didn't have recurrence, and so we were trying to contrast the two. This is now looking at the recursive cell typing. I won't go into this, but what we wanted to do was, visually look at the cause. This is again tissue arrays between patients that had recurrence versus patients that didn't have recurrence. It's almost night and day when you start to look at these tissues directly and really, appreciating the microdomains that you can now map back onto the tissue. And so I asked a really simple question of Chakra. When we go into IO studies, pathologists will say, where are the CD8s? And so when we look at the CD8s, they're across the board, right? Both in responders and non-responders. So CD8s alone, or measuring CD8s alone, is unlikely to be useful, but it's a good sanity check for us before we go in and do the high-plex spatial analysis. And so Chakra's team handled some of the domain network analysis here. We identified the different microdomains in there. Again, immune cell types, tumor cell markers, structural, functional, metabolic markers. These panels are about 60 to 100 markers, and then the goal is how do we define a minimal signature using these approaches. And so this was interesting. So what we found was that there was this M2 macrophage population that was associated with patients that had recurrence in the tumor, and then when we looked at the patients that didn't have recurrence, we had this anti-oxidative stress linked to anti-inflammatory Treg populations. And so when you look at these on the map, you can see that both different sort of phenotypes are present, and they're clearly defining different microdomains in both responders and non-responders, but also can we develop a minimal signature here? So this is just taking all that data in the head and neck study and defining a multi-marker panel. So we've taken about 70 markers, we've drilled it down into a minimal signature of 6 and 5 biomarkers that define both response and resistance. Granzyme B was one of the markers that came up in this head and neck IO cohort. And what was really fascinating was we see this in non-small cell lung cancer as well. This is a study we've done internally in the lab, independent of PredxBio. And we took all the sort of spatial analysis, and what we found was that this same population, this granzyme B population that's associated with proximity to macrophages, is actually associated with a worse clinical outcome. If you want to see more of the study and the findings from this, please visit the PredxBio booth. And with that, I'd probably hand over to Dusty. Thank you.
Thank you. What an amazing talk. Thank you very much.